Good morning, and thank you, Dr. Knecht, and thank you and the organizers for inviting me to participate again this year in this Statements Conference. Larynx cancer is always a topic and that provokes lots of discussion, and so my purpose in the next 10 or 15 minutes will be to set the stage for discussion on where we go from here with integrating some of the newer treatments. As you've heard during this conference, we now have biologics, particularly the monoclonal antibody cetuximab, approved for use in frontline therapy, and we have this resurgence of interest in induction chemotherapy, and what are some of the questions we need to address in the next round of trials. So to do that, I'm going to use the long-term results of the 91-11 and the preceding study, the VA study, to illustrate some of the points that I think we have to consider going forward. And I've titled my talk, Larynx Cancer and Non-Surgical Methods of Organ Preservation. We know that there are there are experts in partial laryngectomy and function-preserving surgery, but this talk will focus on the non-surgical methods. So this is the VA Laryngeal Cancer Study Group trial long-term results that I'm sure you're familiar with. This is a study that was published back in 1991 and that compared induction cisplatin-5 fluorouracil followed by radiation in responding patients to laryngectomy and postoperative radiation therapy. And the long-term survival, all-cause mortality with 10 years of follow-up shows no significant difference in outcome. The surgery, radiotherapy represented by the dotted line. What were the other outcomes besides survival? Well, the larynx was preserved in 62% of randomized patients. This is a crude rate, so there were 166 patients randomized to the investigation or the experimental arm. 103 of those patients had their larynx preserved. Patients alive with the larynx, another crude rate of 66%, which is simply this proportion, 79 patients alive in the last analysis, and of those, 52 had their larynx. This study never actually reported the endpoint of laryngectomy-free survival, which many of us attributed this figure to. These were crude rates, and when we asked Dr. Wolf a few years ago what the laryngectomy-free survival actually was, they went back and determined it, and it was 41%. Pattern of failure, we know that for chemotherapy, local recurrence was significantly greater than the group that were randomized to laryngectomy. We also know that chemotherapy had an impact on distant metastases, significantly fewer distant metastases in the chemotherapy-treated group. And risk factors for surgery, the patients with T4 or N2-3 disease were more likely to need a salvage laryngectomy. 56% of T4 patients eventually required laryngectomy. So the follow-up study looked at three non-surgical treatments and attempted to address this question of the role of chemotherapy. The control arm was the induction arm, same as the VA, with a maximum of 3 cycles of cisplatin-5 FU and radiation for larynx preservation in the responding group. versus concomitant radiation and high-dose cisplatin and radiation therapy alone. Here you see the stratification parameters. Importantly, T1 cancers and high-volume T4 cancers were excluded from this trial. So it was really a very good patient population to test the question of radiation therapy alone and whether induction added to that and the role of concomitant. As you may recall from this data, this was an intermediate stage population. About 70% of the patients had supraglottic cancers, which reflects the population in the US. About 80% were T3 and about 70% N01. The goal of this study was to look at the contribution of chemotherapy and the optimal sequencing of chemotherapy added to radiotherapy to achieve preservation of the larynx. And the current analysis has a median follow-up of 6.9 months out to beyond 12 years. So the endpoints that were evaluated were larynx preservation, local and distant control, overall survival and disease-free survival. This laryngectomy-free survival, which I explained to you, was really something that had not previously been reported. And we mistakenly thought it had been reported in the Wolf trial, was the endpoint that was used to calculate the sample size back in 1990 when this was designed. Just a few comments on laryngectomy-free survival. We think in retrospect that this is a very limited endpoint. It does not account for patients who die from other causes with an intact larynx, and we know in a population with lots of comorbid disease that's not an insignificant proportion of the population. It does not account for patients who are alive with local recurrence and have not had salvage surgery. And it mixes a quality of life endpoint with a survival endpoint, suggesting that patients would give equal weight to these endpoints, and we know that that's not the case. So what was the laryngectomy-free survival outcome for this study? The induction is in white, the concomitant treatment in the yellow line, and radiation alone in red. And you can see with this long-term follow-up that there was significant improvement in this endpoint compared to radiation therapy alone for both induction and concomitant. And here you see the overall rates at 5 years, so about 46% of patients met this endpoint at 5 years, 34% in the radiation group. If we look at larynx preservation, however, we see that the induction arm was not better than radiation therapy alone. There was a 46% absolute reduction in laryngectomy rate with concomitant cisplatin and radiation. And you can see that there was about a 30% laryngectomy rate for induction, 34% for radiation, and half that, about 16%, in the concomitant cisplatin radiation group at the 5-year time point. Also note that most of the laryngectomies are occurring within the first couple of years with a pretty steep decline here, slope, which you would expect. What about local regional failure, which I think is even more to the point because it includes the patients who failed and for one reason or another may not have had salvage laryngectomy. So very important. So there's a 38% absolute reduction in failure for the concomitant chemoradiation group. You see that here in the yellow line, and you see the p-values for the comparison of concomitant chemoradiation to the induction treatment in white and the radiation treatment in red. So I think it's rather striking striking that we have almost half of the patients in the induction and the radiotherapy treatment groups having poor local regional control, and this is with an intermediate population, 30% for the concomitant chemoradiation. So I think it clearly confirms what we knew about induction chemotherapy alone from many other trials that had been done in multiple sites, not larynx specific, that induction did not impact on local regional control. Distant metastases, we saw a low rate of distant metastases, and we saw equal effect from chemotherapy in both of those arms. So what can we say in terms of the preservation of the larynx and local regional control endpoints? I think you can't argue from this data that induction cisplatin 5-FU was no better than radiation alone for preservation of the larynx or local regional control, that both induction chemotherapy and concomitant cisplatin suppressed metastases, but in this population of intermediate stage patients where we would see generally a lower risk of distant metastases, that rate was low. What about local regional control and preservation going forward? Well, what are the questions that we would certainly think about? First, will more intensive induction regimens, the TPF regimen now that has been shown to be superior to PF in efficacy, will that have an effect on reducing local failure rates compared to radiation and cisplatin? And can alternative concomitant regimens achieve the same or better local regional control as cisplatin? We really don't have any data on that. Is intensification of therapy justified for intermediate stage larynx cancer? Should we be looking at sequential therapy? Is it warranted for this group of patients? Or should we be focusing on that for more advanced stage larynx cancer? Overall survival, if we look at all-cause mortality, we see no difference in survival. The 5-year survival rates were 55% for the whole group. It was interesting to see that beyond 5 years, there is a splaying of the curves, but even looking at the comparison of induction versus concomitant chemoradiation, the p-value is solid negative at 0.8. Cause of death. So there was a striking observation that the concomitant chemoradiation group, although larynx cancer was had the death from larynx cancer was lowest in that group, we saw unrelated cancers, a higher rate of unrelated cancers, substantially so, deaths unrelated to cancer or the treatment in that group. And we don't have any good explanation for that. We've had several independent reviews of the data. We've come up with causes of death for all of these patients that appear to be related to comorbid and other disease. And we couldn't explain it on the basis of late radiation toxicities. So if you look at these toxicities, and what I show in this chart is grade 3, 4, and 5 toxicities in these columns under each of the treatments. This is the total number of patients that the toxicities are based on. And these are individual patient numbers. So you see that most of the late toxicity was grade 3. You see that we did have grade 5 toxicities in each of the 3 treatment groups that we attributed to late effects of the treatment. And interestingly, if you sum up these for the induction, the total number of the percentage of patients with grade 3, 4, 5 toxicity was 30%. 33% for concomitant, and 38% for radiation alone. So we didn't see that what we saw in acute toxicity with substantially more acute toxicity for the chemotherapy arms compared to radiotherapy in the long-term follow-up. Now, our method of determining toxicity is, of course, not